Welcome to today's webinar. We're really glad you're here. This is a very important, fascinating topic, and we've got an incredible lineup of speakers for you today. My name is Terry Maxwell, and I will be your host. I do want to let you know that we will be taking questions at the end of today's webinar. You can put them either in the chat box or the question box, and we'll make sure that to answer as many questions as we're able to. We also are recording this, so if you would like a copy of it, you can let us know and we'll make sure that you get a copy of this. I'm delighted to host this topic. I'm a health tech investor, and so I'm always looking for trends and strategies and technology and products that can improve healthcare. And we've got an incredible team to bring this topic to us today, empowering health systems to deliver optimal virtual care. I'm going to start off with our first presenter. Dr. Christy Henderson is the Vice President for Virtual Care and Innovation at Ascension, Texas. She's a clinical professor in population health at Dell Medical School at UT Austin. Her clinical experience has been as a nurse practitioner, practicing emergency medicine, and she has a long history in hospital operations leadership. She currently serves as the Vice President for the American Telemedicine Association and serves on numerous committees focused on advancing virtual care and improving access to care. Christy, welcome to today's webinar. Are you ready to begin?
I'm ready. Thanks, Terry. And thanks to Vivify for hosting this. I think as everyone across the country is trying to really impact healthcare, we're all thirsty for more information. So we're excited to be here to share our story about how we're starting to make a change in improving health and lowering costs. So I'm going to jump right in because we've got the core of the program is going to be with the people that are actually making this all happen. So I want to give you kind of a brief overview about who Good Health is and who we are as an organization, so you can kind of understand the context from which we're coming from. Ascension Health is a national health system that is in 22 states plus DC. And you can see on this map here our footprint and where we're touching in hospitals, senior care facilities, in clinics as well. Our medical group served nearly 2 million people in fiscal year 17. So a very big commitment to serving the poor and vulnerable. As you'll see, we did just under $2 billion in charity care, and it's a very important part of our mission to address the needs of the vulnerable. And what we're going to talk about here about chronic disease management is an entire population that's vulnerable. And so it's important for us, it's important to our mission, and so it's a priority for us. And, you know, it won't be any surprise to anybody just how our healthcare system is failing to meet the needs of citizens across the country. It's disconnected. The people that we serve are dissatisfied with it, and it's way too costly. And so we here at Ascension, Texas, took on an initiative to do things differently. And so we opened what's called the Good Health Solutions Center. And so Good Health is a part of our Ascension, Texas ministry, where we're based here in Austin with 11 hospitals through Central Texas, but we're part of the mothership that is Ascension Health, which you saw in the first map. But when we opened a solution center, it was focused on an entire strategy around access to care and making sure that care was well-serving to our patients and making a difference. And we knew we could do it better. So under one roof, we pulled together a multitude of teams to really provide access to care and care delivery in a whole different way, which was digitally enabled. So our whole goal and our focus is to have a connected and coordinated team that optimizes our resources, but most importantly, provides a quality care and a place where people need it. So when and where people need healthcare, we wanted to be there. And so we're maximizing all our tools and technology to really deliver care in new ways and in new locations. But most importantly, it's truly integrated into the system of care here. And so if someone calls our system to make an appointment, they're given options to get care through telehealth, through care delivery in their home, as well as in one of our brick and mortar locations. And so No longer do people have to think about it separately. It really is getting integrated into our system so that one number gives people all these different options. And so when we built this center, it was really focused around making sure we had a multidisciplinary team where everyone was practicing to the top of their license, that there was one clear mission, that it wasn't a mission from our call center versus our remote monitoring team, but that everybody knew where we were going and what their responsibility was in that whole spectrum of services. So all the resources were pulled from across a multitude of different locations so that the team is sitting together. And so we can have a smarter care team that can leverage the skill sets of multitude of different departments that are necessary to really improve access to care and care delivery. The technology is clearly important to be able to have a full 360-degree view of a patient across clinics, hospital settings, long-term care facilities, home health, and really start to integrate information so that when we serve a patient that we have visibility and we can have a smart team to help make decisions that are best for our patients. And so we're synchronizing information. We're constantly looking at our data to be able to drive improvements and make sure that we provide a white glove service and are improving the quality of life of those that we serve. This slide here really, to me, really depicts the main categories of services that are under our Good Health Service Center. And I want to highlight these just for a minute because the reason our remote monitoring and care coordination program that we're going to talk to you about today works so well is because it's a part of this entire service offering that goes across the continuum of care. So we have a one-call access center. So if you need a bed in a hospital, a doctor's needing to transfer somebody, or you need access to hospital ED services, imaging, our nurse advice line, or need an appointment in the clinic. It's all one site, one location, one number, and you don't have to think about it. But that's where we're also introducing offerings of virtual care. So an appointment for a flu, we will say, you can also download this app and see one of our providers. So a very robust offering through the Solution Center. Our care management team is what we're going to talk about today, so I'll hold on that one. We also do centralized telemetry monitoring, an e-sitter program, and our inpatient diabetes program, but this is really around support services where we can remotely monitor or remotely provide services with our multidisciplinary team from this location to any one of our hospitals or clinics. We have several modalities of virtual care, but we have a clinical informatics team that's really focused on workflow optimization and integration. And then we have a big focus on wellness and prevention as well in the community. Our three modalities for virtual care that we utilize are telemedicine, which is in hospitals and clinics, just really sharing resources and expertise to provide teleconsults real-time and scheduled. But we also have a mobile app that has a digital clinic so we can extend the practices of any of our physicians and nurse practitioners and PAs, but also some of our support staff. So our nurses, dietitians, social workers, extending the platform of how they reach the patients that they manage and serve can be done through this digital clinic. So we have an app that can be downloaded by anyone, and they can enter in through that, and we can schedule an appointment for a virtual visit. Our remote monitoring program with Vivify is one that we started in October that we're going to give you highlights of that journey and really our successes that we're starting to see. But this is it's been integrated into our entire care coordination program. We have numerous programs that are live in our virtual care, meaning telemedicine, telehealth, and digital clinic. But our remote monitoring is on the right in the reddish-orange color, highlighting all the different areas of deployment of using technology to manage patients in the hospital, I mean, as they transition out of the hospital, but ongoing in the home so that they can stay out of the hospital and stay healthy and at work. And so at this point, I want to make sure and hand over this to Megan Metry, who is our clinical nurse manager that oversees care coordination and remote monitoring services within the Good Health Solutions Center. Megan has over 10 years of nursing experience working with a variety of settings in healthcare, including emergency and trauma, critical care, interventional radiology, care navigation, and a robust background in education, which has made her the perfect leader for this program, spearheading that. So I'm going to pass it over to her and let her dig into really a lot more detail about our remote monitoring program.
Thank you, Christy. So as Christy just mentioned, with our care coordination and remote monitoring program, what we did when we started the remote monitoring back in October of 2017, we took our existing care coordination, care management teams that were siloed across our Central Texas hospitals and clinics, and we brought those groups of people together, which was mostly nurses and other allied healthcare professionals, to unify that group and our workflows, but also to put us all together in this brick and mortar building, which has really been integral in our success, being able to communicate easily with one another. So we already really had the platform for care coordination and care management and had that down packed, but we were able to incorporate remote monitoring technology, which opened up a lot of new opportunities for us in being able to efficiently and effectively achieve our patient goals, which we've highlighted: health management, independence, and avoidance of hospitalization for our patients. So our thought with doing this was really under the lens of population health. So I'm sure most of you have seen a similar triangle highlighting kind of the different percentages of populations that we have that are either, healthy or at risk, rising risk, high risk. So we too obviously have similar populations, and we have resources to reach all of those. So we certainly offer some prevention and wellness services to that large base of the pyramid, our healthy population. But since the focus today is really on our care management and remote monitoring services, I'm going to focus us on the at-risk, rising risk, and high risk. And this was important to look at right-sizing these solutions because we have so many different things that we can do, but our patients are all at a different place in their healthcare journey. So we wanted, for our patients, we wanted to make sure that we individualized their care and gave them what they really needed at that time. But also just from a business perspective, we wanted to make sure that we were being good stewards of our resources and, placing a patient with the right healthcare professionals and the right services that they really needed. So the way we did this, we took our care coordination / care management platform, now integrated with the technology, and we said, okay, we're going to offer 3 different levels of service based on that patient's level of risk. So our level 1 service offerings, we do still offer a telephonic outreach if that's what's most appropriate for the patient. Most of our level 1s are going to be a 30-day program duration. These patients are also able to now participate in what our remote monitoring vendor calls BYOD, or bring your own device. So there is some technology available to patients who have their own smartphone and they have the medical equipment they need. So for example, with CHF, they would need a scale and a blood pressure cuff at home. So they're able to participate in our intervention in one of those 2 ways. For our level 2 patients, these are some of our rising risk patients, what we would say more of a medium or a moderate risk. And this duration is typically anywhere from 30, we said 30 to 60, but we would go up to 90 if the patient needed it in this intervention. And the patient would have access in terms of the technology to that BYOD that I just mentioned, as well as the fully scalable remote monitoring kit, which we will describe, I think, on the next slide. So this is the remote monitoring kit. I'm going to have Christy toggle back and forth on these slides for a minute, though. So level 3 is those are our most complex patients. That is usually a 120-day intervention. Most of these patients do get the remote monitoring kit, although if the BYOD is preferential to them, they can certainly interact with us through that technology. Okay, so let's look at the kit really quick here. So our remote monitoring kit, again, our vendor is Vivify for this. Our patients, well, let me tell you what's in the kit first. So the kit is fully customizable. The standard features that it's going to offer, it's always going to have a tablet device available in it, and that tablet device is what the patient is going to be using to complete their daily care pathway questions, but it's also very importantly what they're going to use to talk with our care team members. So the tablet has video conferencing capabilities, so they can request a call from our care team. We can do that via video conference or just a regular telephone call, whatever the patient prefers. But it allows us a lens into if the patient, they can't pronounce the medication or they don't know what it is, or we just need to see, hey, where are you storing your medications? The patient can take that tablet device during that video conference and show us what it is that they're seeing. This also allows us to patch people in. So if we're talking with the patient and we need to involve their provider, we can just easily send a message to the patient's provider and say, your patient has a question about their medication regimen, needing to adjust it, and we can patch that provider in. We can have that conversation with our nurse, the patient's provider, and the patient all at the same time. We can do the same thing with family members if they want to be involved in a conversation with the patient. So the kits are customizable depending on what disease that we are monitoring. So right now, most of our patients are CHF. So for those patients, you would get the blood pressure cuff and the scale. Those are Bluetooth enabled. So the patient just has to check their vital sign reading, and my team of nurses sees that populate in real time in their patient portal. Okay, so as Christy and I have both mentioned, we do have a team of multidisciplinary professionals that are working with these patients. So for the remote monitoring, the primary team lead for these patients is a nurse navigator. That nurse navigator, we're able to offer, through our nurse navigator, we're able to offer 24/7 access for the patient. We do post-op outreach, so I want to highlight this. It's very important. We make sure that we are bridging that gap. If the patient was referred to us from the hospital, we are looking at what happened to that patient in the hospital. We want to make sure that we know what their discharge instructions are, what education they received there, and link up with that. Health optimization, kind of obvious here. Lots of data collection and reporting. The remote monitoring technology has taken that kind of to the next level for us. Care plan development, and of course this says escalation to surgeon, but it's whoever the provider, the physician is overseeing the remote monitoring. We have established protocols in place where we escalate depending on the severity of the escalation to that physician provider home whenever necessary. And then our nurses, as the team lead, they also have access to referring the patient out to a variety of other care coordination services that the patient may need. Ranging from our licensed clinical social workers, our registered dietitians, we have certified diabetes educators, respiratory therapists, really robust care team. We also have PharmDs that work on our team that help us with med reconciliation for our patients that have particularly complicated regimens. And then we also have a variety of spiritual health offerings that we have discovered a large segment of our population is interested in. So core benefits of remote patient monitoring and care coordination, you really don't want to do one without the other, I think. The 24/7 access, the patient-friendly technology, patients really like doing this. They definitely prefer it over a telephone call with their care team. The access to care management, again, we're one click away. So the patient, any time of the day, wants to request a call from us or make a call into us, they now have that available to them. Measurable results, I think goes without saying, that's huge. Improved patient experience, and then of course the lower cost available. We are able to deliver care to more patients, and we're able to do a better job with that care. All right, I have so many of these stories. There are just too many to count right now, but we wanted to highlight one case study of one of our congestive heart failure patients. This is a seemingly straightforward situation, but you guys will quickly see that had we not resolved it quickly, it could have turned into a much larger issue. So one of our patients that we were remotely monitoring had a high alert for their heart rate and also for their weight loss. So heart rate was going up, weight loss was greater than it needed to be. So the nurse navigator, per protocol, contacted the patient to ensure that those were correct readings, that, patient, one of their kids wasn't using the scale or something like that. So once we confirmed that that was a real reading, the nurse was able to escalate that to the physician's home. after finding out that the patient was unable to attend their follow-up appointment after starting a new medication regimen. So the nurse navigator spoke with the cardiologist. They were able to quickly reschedule the appointment and make a change or an adjustment to that regimen in real time. So the cardiologist said, let's go ahead and back down on that dosage. Our nurse navigator was able to relay that to the patient immediately. And it was as simple as that. The patient adjusted their regimen. They were back on track. All their vital signs looked perfect. They weren't symptomatic. But I think this is a situation that highlights easily if that patient had not received that immediate care from their own home, they would have wound up minimally at an urgent care clinic, possibly even the ER. So 3-month program snapshot. Again, we've been doing care management, care coordination for a long time, but we're giving you a 3-month snapshot because this is how long we've been doing remote monitoring technology with that care coordination and care management program. So we have been monitoring over the last 3 months a total of around 300 patients. Our compliance or adherence with the care pathways and vital sign readings that the patient's participating in is around 90%. And our nurses have completed 106 virtual calls with the patient. So our current success, we are just so ecstatic about it. Some of this is, I keep explaining it as it's like too good to be true, but you can see on our program compliance sitting at 90%. That's just almost unheard of to have compliance or adherence rate that high. And that bar that you're looking at on the left there that says RPM, those are for our patients that are enrolled in either the BYOD or the KIT intervention. So they're on the technology itself versus the CMP, the middle bar, which is our patients, that's our patient population that we're still doing telephonic outreach with. So we actually still have a surprisingly high compliance with our telephonic outreach, but you can see the difference between those that are being telephonically reached versus the patients that have those fully enabled kits or the ability to virtually connect with us over their own smartphone. And then on the right are readmission rates, which we're very proud of. So the top orange line in orange, that is our readmission rate here down. These are our Seton hospitals in Central Texas. That's the readmission rate for our patients that did not receive any of these care coordination, care management services. And in blue is the rate of our patients that we did put through our care coordination remote monitoring services. So for the final dot on there is the average, and our hospitals who had, or a patient population that was not navigated was sitting around 23% 30-day readmission rates, and our navigated patient 10%. So really excited about those results.
So I'm going to transfer over to Dr. John Schlitt, but I want to quickly introduce him for you, and you'll know quickly why we're so excited to have him join our team. So Dr. Schlitt is the medical director for us here at the Good Health Center over our virtual care and innovation arm of the work. He's been a practicing anesthesiologist with Capital Anesthesia Association for over 10 years. He stood up our perioperative surgical home. He had a brief career on Wall Street prior to going to medical school, and retains an active interest in business of medicine. So we're thrilled to have him join the team. And I wanted him to come on and really speak from the physician's perspective, but also around the future of where we're headed with all of this. So Dr. Schlitt, I'll pass it to you.
Thanks, Christy. And I appreciate everybody who's on the webinar. I think the best way to give everybody sort of a feel for my perspective is to tell a little bit of a story about the journey into virtual care and innovation. This all sort of started from my perspective and my anesthesia group's perspective when we sort of were asked to help partner with the hospital system in Austin, Seton. We've got about 7 hospitals in Austin that we service, and come up with a response to some of CMS's bundled care initiatives. For those of you who are in healthcare or are clinicians, you know that those bundled healthcare initiatives are really focused on the value-based healthcare equation, which is maintaining or improving quality while decreasing costs. And the first bundled care initiative that we were asked to help solve for was the Comprehensive Center for Joint Replacement, or CJR, which focuses around orthopedic lower extremity elective total joints. And the response that we sort of came up with when we partnered with Seton was to create something called a perioperative surgical home. Under that umbrella, and this is sort of endorsed by the American Society of Anesthesiologists, we kind of envision it as an umbrella, and under that umbrella, the goals were really to not only focus on the patient's surgical and in-hospital experience, which is traditionally sort of where anesthesiologists have been focused, but to take a much larger scale view of the patient's journey and really help with transitions across levels of care. And so we initially realized that we needed to get a hold of these patients early, ideally up to 4 weeks prior to surgery, and begin to really dose education, set expectations, risk stratify these patients, take the high risk patients and optimize them for surgery, set standard protocols and clinical pathways for their in-hospital experience, and then also manage them into the post-acute setting, whether that be inpatient rehab, skilled nursing, or to the home environment. And CMS mandated that we would be measured on this episode for 90 days postoperatively as well. Now, as a physician, I think we are all fairly comfortable coming up with best practices. So, having reviewed the literature, it wasn't all that difficult to come up with best practices for protocols and pathways in the hospital setting. But some of the challenges were, how do we integrate 7 hospitals so that we can all do this the same way and eliminate variation and medical error? How do we spend the time with the patients that we really need to make sure that that education is being dosed over time so that they're not just bombarded with information? How do we appropriately risk stratify these patients? How do we get them optimized when historically, they may be seen by a primary care physician prior to surgery, and as an anesthesiologist, I get a prescription that says the patient is cleared for surgery when it's fairly apparent to me that they weren't really clear for surgery. And so when we started to look at how to create an integrated network solution for many of these things, we just happened to stumble upon the Good Health Center and the variety of offerings that they had. And we realized pretty quickly that there was going to be no way for us to really execute on this perioperative surgical home without their involvement. So what we did is we basically started utilizing this care coordination and care management team to really help engage not only our surgeons, but also our patients very early in the process, and basically give them a single point of contact, that being that nurse navigator, a single phone number to call with any questions or concerns, and then really begin that risk stratification, education, and expectation setting early in the process. We also stood up an optimization clinic. Soon there will be 3 in our entire network so that we can service patients in our North Market, our Central Market, and our South Market, and then really begin optimizing conditions that we felt were necessary to be optimized prior to the patient having a positive surgical experience. Once that was done, then again, the transition into the hospital, managing that transition was important. So how do we do handoffs to nursing staff, to clinicians that are going to be caring for these patients in the hospital? And again, our solution was to utilize this sort of all under one roof Good Health Solution Center. We were able to execute, albeit with some time, energy, and effort, sort of standardization of our protocols in the hospital. And I think that's where, as a physician, we're historically most comfortable. And so that felt a little bit easier to tackle. But then again, we had to figure out, how do we transition these patients out of the hospital and where were they going to do best? And we realized from looking at CMS data that elective lower extremity joint patients were going to do best, have better outcomes, less readmissions, less ER visits if they went home. Well, historically, these patients felt, and I think it's sort of become a culture, at least in Central Texas and Austin, that they needed some higher level of medical care, and they wanted to go to inpatient rehab facilities, and they wanted to go to skilled nursing homes where they thought they were going to be seen more frequently by nurses, by physicians, and get a higher level of care. But as we dug into the data, we realized that clearly that was not the case, and there were improved outcomes at home. And so transitioning these patients from the hospital, setting expectations about going home, and then the key, following these patients at home and making sure they were following their PT protocols, following their medication recommendations, continuing to absorb all of that education about what was critical was a big part of the challenge. And again, we had the luxury of having the Good Health team and this care coordination effort to help keep us integrated and guide that. And so we implemented that about, I would say 12 to 18 months ago or so. And we've continually been looking to do plan, do, study, act cycles to improve this. And I think, again, from my perspective, what I've become most excited about, and sort of what led me to becoming a full-time part of the Good Health team, was that the technology offering, the remote patient monitoring and the Vivify platform is really what's going to allow us to scale this effort. As you can imagine, utilizing phone calls and nurse navigators, and taking 23-hour admit histories on patients, doing medical reconciliation, dosing education is very, very time consuming. And so it's very FTE intensive. And so when we did our plan, do, study, act cycles, it became very apparent that unless we could really scale this project and have a low number of navigators carrying a high patient load, we weren't really going to be able to move the needle in a cost-effective manner. And so as we looked into what the Vivify platform and remote patient monitoring allows us to do, we realized quickly that was going to become a critical piece to our solution. And so we are in the process of rolling out Vivify and remote patient monitoring to our lower extremity total joint population, and couldn't be more excited because it really decreases the FTEs needed to service this population and allows us to automate things like education, patient questions about wounds, medication compliance, push out videos about exercises that need to be done at home, things like that. And we are thrilled to embrace that technology and utilize it. So next slide. So again, similar to Megan's slide, just a quick example, although I have many, and I'm a talker, so I'll probably throw a couple in there. But one of the things we realized early is one of the highest risk pain points for post-surgical joint replacement patients is DVT risk. And this is one example, but we've had a number of them where we have patients that are taking, they go home on multiple different multimodal pain medications. They go home on NSAIDs, they go home on aspirin, they go home on other blood thinners if they're high risk for DVT like Eliquis. They go home on mixed narcotics like Norco and Percocet that have both oxy or hydrocodone and acetaminophen in them. And so patients very easily get confused. And traditionally, as an anesthesiologist, I never saw that part of the spectrum and never realized if a patient was going to be at a high risk for a post-surgical hematoma because they were taking too much anticoagulant, or be at high risk for DVT because they weren't taking their anticoagulation regimen appropriately. So in this case, our nurse navigators that follow these patients for 90 days post-operatively, and the way they do that, as just an aside to the audience, is these patients are risk stratified, as I mentioned earlier. So the highest risk patients get much more frequent follow-up. The lower risk patients get less frequent follow-up. But anyway, these patients, as they're followed for 90 days, the nurses consistently, as we've collected our data, make sure they go through medication regimens. And in this case, the patient was taking both aspirin and Eliquis. The nurses were able to identify that as an issue. Medical reconciliation was provided based on the patient's DVT risk, and we avoided a potential hematoma, ER visit, or readmission. And in a world where we're being measured by CMS on cost as well as outcome, we feel like we're able to make a difference. So that's a little bit about my story, my journey, and what led me to become part of the Good Health team. I hope that sheds some light on things from a physician's perspective, and I'm going to hand it back to Christy. Thank you.
Yeah, thank you, Dr. Slid and Megan, for your insights into this. I think we're still learning a whole lot about how to truly optimize technology in our care delivery system. And when we start thinking about what's next and our challenges and our barriers, you know, none of this is easy. If we think about implementing the electronic medical record, no one just signed up to start switching from a clipboard and paper to an electronic medical record. And so understanding the change management that goes in with this will help you manage expectations from your health system or patients and others around the adoption of this. So I think we have learned an enormous amount now doing this at more than one system. It's very similar challenges. You've got to get in that workflow and understand how to integrate. The technology possibilities are never ending, and every day we all see new startup companies, new offerings, and new technology. But one of the things that has consistently been an enabler for our success has been that we've really use technology to allow us to deliver the best-in-class standard of care that's already established in new ways. And so we're not trying to change too many variables. It's just how we deliver that care and where we deliver it. And the care team is dedicated to that. And so the technology will continue to evolve and integrate better, and will allow us to not have to have, 10 passwords to multiple different platforms to be able to have that full visibility to the health of the people we serve. But as the monitoring capabilities really become ubiquitous to a patient's environment and to their activity, we really have to be able to manage a lot of different data points coming from a lot of different places, and the Vivify platform has allowed us to do that. And so all of our care management is in one dashboard, so that the care team can really understand where to spend their energy and time and prioritize their activities to make sure that we are good stewards of our resources, and are also making sure we balance the number of interventions for patients. We don't want to do too much that results in disengagement from the system, but we want to do just the right amount to make sure and keep them healthy and living independently and outside of the hospital. And so that's really been a focus of ours. And so the what's next piece of this is we're going to continue to optimize this and rescale this offering. It's working in multiple different populations and disease states. And so expanding that and integrating it will be our continued focus, and reporting the outcomes and disseminating the success to others so that it can be replicated across the country. So I know that we're going to open it up for questions, and I think we're at the mark where we want to do that. So Terry, I'm going to pass it to you to let you kind of facilitate entry into that, and we'll be glad to entertain anybody's questions.
Awesome. Thank you, all of you, so much. We do have a lot of questions that have come in, and several people asked this first question. Why do you think this program has such a great adoption and engagement? I mean, a 90+ compliance is amazing. What do you think the root of that is?
It's the balance of the use of technology and the people and the integration into people's lives, or the integration into the workflow for the physicians. Adoption and compliance there's multiple pieces to truly get engagement by a patient. They have to trust the system. They have to see the value in it. It has to not be too much or too little. And so that fine tuning is really a result of our care team that is so skilled at what they do, but using technology. And so that assessment to determine what type of technology to use is really important. And the functionality within the fully managed kit, remote monitoring kit, really allows a relationship to build. And I know that Megan can add more to that, but that patient interaction is critical to adoption. So I'll let her add to that.
Yeah, Christy's absolutely right. I would really highlight patient engagement and physician engagement as being integral to the success of this technology really working for our patients. We don't want to replace that relationship that we form, which is usually a face-to-face that happens with the patient. Now, it doesn't necessarily have to happen from our team. Sometimes it does. We certainly have deployed what we refer to here as health promoters into our hospital settings to go and talk with patients when they're identified as good candidates for this technology. We want to make sure the patient understands what it is that we're doing here, and that it is something that they are interested in and excited about. But we also, that engagement that we have with these physician and provider homes is important too, because we want that warm handoff from them. Our adoption is much better whenever the patient is visiting their cardiologist, and their cardiologist can say, how is your remote monitoring going? I see, I just got some results from your nurse navigator, and I can see that your blood pressure has been doing better, or whatever that is. So I think that has been really, really important for our success. That we put a lot of time and energy into communicating with our patients and our physician and provider stakeholders.
Yeah, and this is John Schlitt. Again, from the physician side, I just want to make a comment about that too. And Megan hinted at this, it's about picking the right patients. Although ironically, for this audience, you would think the right patients would be patients that are technology savvy, have phones at home, are comfortable using tablets, but that's actually not the case at all. And in fact, Megan can speak to the age and overall technology familiarity level of our patient population, and you would be surprised at some of those facts. But really, picking the right patient is a patient that wants to be engaged with their care team, although inherently understands that, and maybe even subconsciously at times, that they are going to do well at home, and they're motivated to want to stay home in a comfortable, safe environment for them. And when you find patients that are properly motivated yet are looking for that level of engagement, y'all heard me talk about inpatient rehab and skilled nursing homes. Patients understand, I think, on a subconscious level, they're not really comfortable there. They're just looking for the clinical care and the engagement that they get at those places. So when you have a patient that is comfortable at home yet still is yearning for that engagement with their clinical care team, those are patients that become excellent candidates for this. And so picking the right patients and allowing for that real personal interaction that doesn't rely on a phone call, which is kind of tedious, and we all sort of feel that the impersonal nature of that interaction sometimes is really key to also the compliance of this program.
Thank you very much. The next question is kind of goes along with this, which is why I've grouped it in here. What do you think is more important? Just a kind of a trade-off question to reduce readmissions and or length of stay. Is it the tablet so that the patient is self-reporting data and therefore they're getting involved in their own care, or how is it the continuous monitoring of the vitals? What do you think is more important and why?
Terry, that's a great question, and I'm going to let the two clinical folks speak to that. But at a high level, I hate to say it depends, but it truly that's the beauty of this product, is that while there's some standardization that allows you to be able to scale, there's individual customization that allows us to adjust based on their needs. And we have that constant data points that we get from vital signs and their biometric monitoring, but there's such a robust data collection that exists in these health surveys and in the video chats. I'll let them chime in, but it across the board, I would say that all of it's important, but it depends on the individual.
Yeah, I would agree with Christy. I think they're both important, although just anecdotally what we have seen over the last few months is, if you just want to force my hand and pick one, I think the ability for the patient to conveniently do this at their own pace, at their own time, has been probably the most important. So just the ability to pull out that tablet, answer their care pathway questions, and do their vital signs, that has been the biggest win really for our patients in terms of satisfaction, because these are busy individuals and they don't always have the time to sit on a call with us, even if it is the cool video conference call. But being able to have a system where they can quickly enter their vital signs and answer questions about their health, again, at a time that's convenient for them. I think that's probably been the biggest patient win.
Yeah, and I'm going to actually echo many of Megan's sentiments. You know, I think we live in a healthcare world where we have access to all kinds of scans and lab information and data. And as a practicing clinician, I think that those are really important. But the more that I've become involved in the bundled care initiatives, the perioperative surgical home, and sort of monitoring long-term patient outcomes, I think the patient engagement piece really outshines just having sort of continuous data. You know, if you ask me to pick between having continuous blood pressure, pulse oximeter, and EKG readings from a patient at home versus having an engaged patient that was willing to answer questions like, how do you feel today? How does your wound look today? From a CHF perspective, what CHF zone do you think you're in today? I think that I'm learning that I think that level of engagement and the answers to those questions can many times be more high yield than just having straight data coming back in.
Excellent. Next question is a good follow-on as well. Do you see post-discharge monitoring at home being essential? And if so, what are some of the opportunities and challenges that you've seen?
Yeah, this is Shalette. I'll jump in first on this one if you guys don't mind. I think that's an excellent question. And that one, I sort of do say it depends. As you guys heard me mention earlier, as we look at particularly our surgical patients, and these patients are getting risk stratified. And so I think our high-risk patients that are brittle diabetics or poorly controlled hypertensives or have significant levels of anxiety and depression or are New York Heart Association Class 4 CHFers that are either getting ready to have or recovering from surgery, I think targeting that population for the monitoring and the data is critical. But when you get into your more sort of moderate and low risk patients, I don't believe that it's as critical and necessary. I think that engagement piece, the education, the expectation setting, the patient questions, I think those things are much more critical for your low and moderate risk patients.
Excellent. I want to shift gears because I've got a couple of logistical questions that keep popping up. The first one is, do you manage kit logistics internally or did you outsource this to another company?
Yeah, so we, the kit logistics piece, we for the most part manage on our own. Now, certainly we work with Vivify support on issues that we're unable to resolve independently, but that is part of our workflow, the kit logistics piece. So we do actually have a person that oversees that and makes sure that the kit is appropriately deployed and arrives and that we get it back. So I would say like 90% of that we are doing ourselves, with the additional help coming from Vivify support on that.
The only addition I have to that is that the repurposing of the kits we don't do internally.
Yeah, that's correct. We don't reprocess the kits. We just kind of manage where are they going when they get there. Yeah.
And we do deliver in two ways. One is directly to the patient if they're in the hospital and or a clinic and we want to deploy that way, or we will have it delivered directly to the patient's home.
Excellent. Another kind of business model operations type question. Some health delivery organizations are choosing to outsource chronic care management. Do you think that remote patient monitoring can be outsourced for those clinicians interpreting the at-home patient data?
Yeah, well, we strongly believe that the answer is yes. That's our whole model. While we are a part of a health system, we are not within the physician practices or in the hospitals. We're in a remote location, and in that communication and understanding the protocols at which we decide what we do with an abnormal, question or an abnormal vital sign is critical, but that can absolutely be built and managed remotely. So, we are, while we are part of a health system, we are a standalone entity as a Good Health Solutions Center that offers remote monitoring services to others.
Yeah, and
here's another great post. Go ahead.
No. I would definitely echo Christy's sentiments and only add a couple of things. If you look at sort of analogous business models, right? In today's day and age, payroll is often being outsourced for large corporations. HR is being outsourced for corporations. I think the cost associated with and the FTE intensive nature of doing this kind of work is potentially prohibitive for some, smaller or community-based healthcare systems. And I think that over time, I predict that you will see those healthcare systems, as they adopt the inherent value that I believe exists with this type of technology, will probably lean toward some of the larger healthcare systems and more financially nimble entities that have the infrastructure in place to build the comprehensive teams and incorporate the technology that's necessary to execute on this type of business model.
Excellent. Next question, and this is, I think, is a really good operational question. I see this asked a lot. For virtual visits, are patients able to call the clinicians at any time, or do those virtual visits have to be scheduled?
Yeah, so the patients that do receive the remote monitoring technology, whether they're doing it through their own phone or the tablet device, they have the option of requesting a virtual call with one of our nurse navigators. So it's like a click of a button. It's just request a call from your nurse. The patient can choose if they want that call immediately or if it's something that can wait until a little bit later. So they're able to give us kind of the urgency of the call. And then in addition to that, while we don't have right now the ability for them to call directly to the nurse navigator, if they do have an urgent concern and they want to call our 24/7 nurse triage line, they're able to do that. And then in doing that, the nurse triage line will route them back to our nurse navigator if and when that is appropriate.
One of the beauties of the Good Health Solutions Center is, she just mentioned another the 24-hour nurse triage line. They're all here in the same center, but we also have our digital clinic staff here so that while you can't call in and get your physician directly, you will get your care team leader, your nurse navigator, who will then determine who else needs to be pulled in. And so that may be pulling in the physician, and that's coordinated with their availability, but it may be somebody else on the care team as well, as we mentioned earlier. So the nurse facilitates all of that, but across the different disciplines and divisions in our Good Health Center, it can all be managed here. So it doesn't have to take unnecessary time or more phone calls or transfers among different teams. So we can facilitate a video consult with a provider through the Vivify platform as well.
And another operational question, is your remote monitoring solution integrated into your EMR?
Great question. So no, not yet. There's pieces of it that are, and I'll let Megan speak to that. But as far as our care summaries and things like that, we are documenting within Vivify, and it is not a full interface. It's a feed directly into our EMR, but we're putting care summary reports into our EMR so that we can have visibility of that and the providers can have visibility to that. We didn't want to do data overload, so each entity that decides to roll forward with a program like that, that's a critical piece to understand what is actionable information versus just data points that are all important, but we chose to put care summaries and intervention reports into our electronic medical record here.
Excellent. We've got time for one more question. Dr. Schlitt, you indicated that outcomes have been better at home than in post-acute settings. Does that involve home care visits or just remote patient monitoring?
Yeah, that's an excellent question. I think that probably the bulk of the literature today supports outcomes being better at home that are home with home health. Although I will tell you, as Christy mentioned, as we continue to adopt this technology and it's in its infancy, as we continue to adopt this technology, Seton serves a large underprivileged population that may not, in some instances, qualify even for home health services. And so we have a significant number of our patients that are being trialed at home with outpatient physical therapy and remote patient monitoring. And to date, internally, our data shows no difference in outcomes, cost, readmissions, or ER utilization between home with home health or home with outpatient physical therapy and remote patient monitoring technology. And again, because this is in its infancy, those publications have not been done, but through our affiliation with Dell Medical School and the partnership between Dell Medical School and Seton, there will probably be some publications that come out of this work. So I would tell you that the literature supports home with home health, but we have found that home with outpatient physical therapy and utilization of RPM and technology and care coordination, we have about equal outcomes in our healthcare system.
Awesome. Well, if that's all the questions we have time for, there are some others. I'll make sure that those get passed along. I want to thank our three panelists, Dr. John Schlitt, Megan Mitri, and Christy. You were just phenomenal. I think the vision that all three of you have is amazing, and the results that you're getting are just, they're just mind-blowing. For those of you that tuned in late, or if you would like a copy of this recording, we will make it available probably next week. We'll get it up on our website so that you can download it. Again, Christy, Dr. Schlitt, and Megan, phenomenal work, excellent presentation, and superb insights. Thanks, everybody. We appreciate your time.
Thank you.
Thank you.